My question is, after you do a successful procedure, I mean, some of these patients would have been on an oral anticoagulant or a NOAC for that matter. How long would you continue this? Would it be 3 months, 1 year down the line? So what is the chance of somebody developing a stroke at the end of 3 months, 6 months if you discontinue the anticoagulants?
Yeah, it's a good question. Honestly, this is a question which has been discussed 2 years ago on many conferences because everybody wants to stop after successful ablation, the anticoagulation. This should be the target because right now, treatment says we do ablation, we give for 3 months oral anticoagulation, and afterwards we look for the CHED-SWAS score and lifelong anticoagulation, even though the patient has been ablated. So concerning this topic, honestly, we don't have the results so far. But there are some trials running on, randomized trials, analyzing and comparing patients after ablation with discontinuation of oral anticoagulation and continuation. So this means, I would guess, in 2-3 years we know more about that. But at the moment, nobody knows. So at the moment, so far, if we talk about our patients, I would continue.
And one more question is, we have seen CRT, helping us in terms of reverse remodeling and things like that. What happens to LA remodeling? So once you do not very early in the disease, but maybe once the LA is dilated a bit, and you think this technology will make any impact on that?
Yeah, there are some studies on that topic. There will be no remodeling. In an advanced stage, it doesn't make any sense anymore. So forget if the left atrium is 60. But early stage is maybe not the right point. But if you have a patient with a left atrium, not lavi or left atrium size of 45, and he has some scar anterior wall and posterior wall, and we analyzed this with my old group. I remember that very well. And there are also some other Japanese studies on that topic. And you can see in a certain number of patients regression of the LA size and less fibrosis along the anterior wall. But honestly, there are too many confounding risk factors which can, on the other hand, enlarge again, even though the patient is in sinus, or create fibrosis. This is what we had in the first talk about the risk factors for AF, because we don't know if there's a patient asymptomatic AF after ablation. So, but we have we have some data which showed already that left atrial enlargement can be stopped, and fibrosis as well. There are some data on that, yeah.
Apart from the access site complications, can you give us some more on what are the potential complications which I have to explain to the patient before I take the patient?
Very important. I always tell the patients, most of the patients do not know too much about catheter ablation, but most of the patients know what a PCI or coronary angio is. I always start and say, okay, it is pretty much similar like a PCI procedure. Then they know, okay, there's stroke risk, there's a groin complication, and then I usually say, okay, there's a certain reason for risk for pericardial effusion, tamponates, but this is with this technology pretty much low. So there's another complication which is with this, which might be a bit higher with single shot devices like the cryoballoon compared to radio frequency, and this can be a palsy of the phrenic nerve. So if this occurs, then the diaphragm on the right side won't move after procedure, and this can happen during ablation of the right superior or right inferior pulmonary vein. On the lateral side, not. The diaphragm on the lateral side goes epicardially, and here along the septal pulmonary veins. Important, and this is something the patient has to know. In most of the cases, the phrenic nerve palsy will disappear and everything will be fine already within the procedure. If not, in almost, I think, 70 or 60 or 70% within the next couple of months, and almost every patient will be fine after 1 year. So this is something which resolves after a period of time by itself. And most, this is from my personal experience, most of the patients are not too symptomatic with that. Symptomatic are patients, young patients who do a lot of sports, marathon runner or cycler, but the normal patient with a phrenic nerve palsy on one side won't be, in most of the cases, won't be too symptomatic. So this is something the patient should know. Yeah. The risk is 2 to 3%.
I think we had an excellent discussion. I think I would like to open this to the audience. Any questions from the floor? To all the three speakers, I think.
Sir, we are in the process of working it out. So it will be costlier than the radiofrequency ablation because there's a cost attached to the balloon. But we will keep it affordable. May not be very costly. Like I think outside India, cryoablation is AF ablation as such is a very costly procedure. I think in India, we'll at KMCH we'll keep it as very affordable. Exact price, I think we'll work on it.
How much it costs in Germany?
I think this should not the question. The procedure will be completely reimbursed by the German healthcare system. So the hospital will get a certain money for every PVI procedure. Either it's not important if it is the first PVI procedure or the 10th PVI procedure in one patient. 10 procedures doesn't make any sense, I agree on that. But however, it is completely reimbursed. And this is the main difference.
I don't think I have not been in a position to. But I think the kind of work we are going to do, I think it's not very costly. It's not very costly. Like whatever we acquired, it's not that costly. I think that's the reason I told that we can keep it at very affordable because most of the patients who are eligible for cryoablation should be able to afford it. I think I don't think it will be very cheap like a radiofrequency ablation, but it will be definitely affordable.
How do you ensure the transmodality of the cryoablation? Especially in the wake of the fact that the antral muscular morphology and the thickness might vary from patient to patient.
You can take the question.
Okay, I take over. You cannot visualize it at that point. If you want to visualize, you have to do also a 3D map or you go for an MRI. But I think this is much expensive, doesn't make sense. So how can we be sure that, I show you, here, look here. This is the proof for us when a PV is isolated. This is the septal vein, this is the balloon. And just have a look here. This is the surface ECG. Everybody can see this is atrial fibrillation ECG, irregularity of QRS complexes. And what you see here, these are the signals we get from the pulmonary veins from here. And we start with the freeze. And what you see here, the signal within the pulmonary veins gets slower. It gets slower and slower and slower. And then at the end, it disappears. And once it disappears, we know the pulmonary vein is isolated. If there's really 100% transmurality, only God knows. We do not know of. This is the acute outcome. Yes. Yes. You can see it only with MRI. If you want, you can see it only with MRI. Or you have to do a remap. You can remap the ostium, and once you see scarring around the ostium, then you're sure that you have a transmurality. Yeah. But if the patient wins. If the patient has no more symptoms and no AF, then the question is, you know what I mean? Yeah.
So I think if there are no further questions, I would like to thank Dr. Shibu, Dr. Thomas Alexander, and Dr. Lawrence for this wonderful session. And then on behalf of all the panelists, I'd like to hand it over back to the organizers. Dr. Lawrence.